Welcome back to the Explainer. When you just glance at a hand, it's pretty easy to only see skin and a few creases. But if we really dive into the source material, we find this breathtaking, highly complex 3D architecture hiding right underneath. It's literally a landscape of tunnels, pulleys, and completely hidden compartments. Today we are going to focus on one of the most clinically significant, yet totally invisible structures in the human body, the mid-palmar space. We're going to map out its boundaries, figure out exactly how it's built, and uncover why knowing the layout of this hidden room is absolutely crucial in a medical emergency. Let's get into it.
Imagine this for a second. A patient walks in, and their hand is heavily swollen. The skin is incredibly tight, and they're in excruciating, throbbing pain. The pressure is quite literally rising by the minute. So what exactly is going on here? Well, what actually happens when a deep infection gets completely trapped inside the palm? The answer is all about the structural design of the hand itself. Before we throw around heavy anatomical jargon, we need to establish the sheer clinical stakes here. You see, the hand isn't just one solid block of muscle and bone. It's highly compartmentalized. When harmful bacteria get driven deep into the hand, say from a bad puncture wound, that infection doesn't just spread randomly. It follows the path of least resistance, filling up these specific hidden rooms until the pressure just becomes unbearable.
To really grasp what's happening, we've got to define what these rooms actually are. In anatomy, we call them fascial spaces. Now, the key concept to remember is that these are potential spaces. On a normal, healthy day, you wouldn't even know they were there. They're basically just areas filled with loose connective tissue, quietly hanging out between the much denser structures of the hand. They only reveal themselves, expanding into distinct, measurable cavities when something goes horribly wrong. Specifically, when fluid or pus from an infection starts collecting in them. It's that rising pressure that inflates these potential spaces into very real, very dangerous anatomical rooms.
If we slice through with a transverse cross-section, our focus lands slightly medially on the mid-palmar space. You'll also notice its neighbor, the thenar space sitting over on the lateral side. Visualizing this layout instantly shows you how these spaces act as totally distinct anatomical rooms. They're completely walled off from one another by thick connective tissue sitting deep beneath the skin and superficial tendons, right on top of the deeper muscles and bones.
All right, moving on to building the fascial framework, the walls and ceilings.
The deep fascia of the palm is actually pretty thin over the fleshy hypothenar and thenar eminences on the sides. But right in the dead center of the palm, it thickens up dramatically to form what's called the palmar aponeurosis. This is a really strong triangular sheet mostly made of longitudinal fibers. Morphologically speaking, it's actually the degenerated tendon of the palmaris longus muscle. This super tough layer covers the long flexor tendons and the superficial palmar arch. And for the mid-palmar space beneath it, this aponeurosis acts as a firm, completely unyielding sealing. Because it's so incredibly tough, any infection trapped underneath just can't push its way up to the surface of the skin. Instead, it forces all that pressure to build deeper and deeper inside the hand.
Connective tissue actually drops down from that aponeurosis ceiling to anchor itself to the bones below, which creates two absolutely crucial dividing walls. First up is the medial palmar septum. This guy extends inward from the medial edge of the palmar aponeurosis all the way down to the fifth metacarpal. That creates our inner wall, sealing off our mid-palmar space from the hypothenar muscles. Next, we have the intermediate palmar septum. This wall drops down at an angle from near that medial edge all the way over to the third metacarpal. This intermediate septum is the real game-changer divider that entirely separates the mid-palmar space from the thenar space right next door.
Let's step inside the mid-palmar space for a 3D tour. Okay, imagine you're standing directly inside the mid-palmar space. Look up, and the anterior ceiling is made of that tough palmar aponeurosis, the superficial palmar arch, the digital nerves and vessels for the medial fingers, the ulnar bursa, and the medial 3 lumbrical muscles. Look down, and the floor beneath you is formed by the fascia covering the interossei muscles and the medial 3 metacarpals. You're walled in laterally by the intermediate palmar septum and medially by the medial palmar septum. Now, proximally, towards the wrist, this space doesn't just hit a dead end. It actually communicates directly with the space of Perona in the forearm. Distally, towards the fingers, it continues into the medial 3 web spaces through the medial 3 lumbrical canals. It really is a highly specific, intimately bordered little compartment.
Contrasting this room with its neighbor, the thenar space, really clears up the clinical picture. While the mid-palmar space sits under the inner part of the palm, bounded by those third and fifth metacarpals, the more triangular thenar space is located under the outer half of the hollow of the palm. Because they are strictly separated by that intermediate septum, their drainage pathways are completely different. The thenar space communicates distally with the first web space,
But the midpalmar space? That communicates distally with the medial 3 web spaces. This isn't just a bit of anatomy trivia either. This difference literally dictates exactly how an infection is going to spread.
Now for the clinical stakes and infections, the pathway of pus.
In a real clinical setting, obviously, a patient presents with a swollen, agonizingly painful palm, not a perfectly neat cross-section. But by projecting the boundaries of these deep spaces directly onto the surface of the skin, a physician can pinpoint the exact problem. The midpalmar space projects right over the central and medial part of the palm, while the thenar space projects over the fleshy base of the thumb. So a tender, bulging swelling specifically over that central medial area immediately signals to a trained eye that, hey, we are dealing with a trapped midpalmar infection.
Tracking the pathway of this infection step by step really shows you how the room fills up and eventually bursts. Step 1 is the inlet. The ulnar bursa, which is the synovial sheath enclosing the flexor tendons, is considered the primary inlet for infection into this space. If that bursa gets infected, it leaks right into our hidden room. Step 2, the room fills up. That potential space expands, the pus builds, and because that tough palmar aponeurosis ceiling just won't give way, the pressure causes absolutely severe pain. Step 3 is the outlet. The pus travels distally, following the path of least resistance right through those medial 3 lumbical canals and into the web spaces. And finally, step 4 is resolution. By knowing these exact outlets, a surgeon knows precisely where to make the incisions to safely relieve all that pressure.
The source material actually makes this explicitly clear, and it is a massive takeaway. Quote, "The ulnar bursa is considered as the inlet for infection, and lumbrical canals as the outlets. The pus from this space is drained by incisions in the medial 2 web spaces. If a surgeon isn't intimately familiar with this architecture, they could easily cut into the wrong compartment. They might fail to drain the midpalmar space entirely, or worse, accidentally damage the delicate digital nerves and vessels that form the anterior border of the space. The anatomy absolutely dictates the surgical solution here."
It really is incredible how structured we are underneath our skin. A seemingly flat palm contains this distinct, fully walled-off room that only reveals itself when disaster strikes. The human body is just full of these intricate fascial planes, which leaves us with a pretty fascinating thought. With such complex inlets, outlets, and hidden compartments residing just beneath the skin of our hands, what other hidden spaces in the body might be acting as potential rooms, just waiting to harbor invisible threats? Keep that curiosity alive, and thanks for joining me on this explainer.